Thank you, Carlos. Thank you for your kind invitation to come and present here. I chose this topic because I think we have amongst us what we're now calling direct oral anticoagulants, but we're not done yet in terms of inventing new anticoagulants, and the work for that development usually starts in the lab. So I'm going to give you about 2/3 of the talk will be sort of on more theoretical issues of why factor 11 and or factor 12 are being thought of currently as targets for anticoagulants, and then tell you a little bit about what actual work is being done by companies, mostly preclinical work. As you know, none of these are approved right now. These are my disclosures. As I say, we'll start off talking about why one might want to target factors 11 and 12. We'll talk a little bit about what human deficiency states have told us about factors 11 and 12. And then really we get into some of the preclinical models, which at this point are mostly in animal models, usually small animal models. And I'll show you some of those data that have really promoted the field of exploring factor 11 and factor 12. And then we'll finish with a little bit of just sort of a listing of what is going on in this area right now. I'm not going to go into the details of the preclinical data so far. So if we think about patients who have low factor 11 or factor 12 levels, we know something about the epidemiology. It's certainly not perfect by any means, but we know that patients with factor 11 deficiency can bleed, but they don't bleed spontaneously. They only bleed with trauma. And therein gives an opportunity, I think, to think about factor 11 as an antithrombotic agent, just because the bleeding pattern would be different from targeting factor 8 or factor 9, for example. A low factor 12 level, as you know, is not associated with any bleeding at all. When it comes to thrombosis, if we look at the other side of the coin and we think about high factor 11 or factor 12 levels, this is the best data that I was able to pull out for the ASH educational program on what we know currently about factor 11 and factor 12. That is that factor 11 appears to be a risk factor for venous thrombosis and for ischemic stroke, but not really, strangely, for myocardial infarction. Now, it may be that the right studies haven't exactly been done, but that's what we have so far. Factor 12, on the other hand, is completely neutral. All the studies have looked at elevated factor 12 levels, been unable to show that it's a risk factor for any kind of thrombosis. So we all teach our medical students the very classical view of coagulation with the extrinsic and intrinsic pathways as two separate entities. And importantly, what we talk about when it comes to the intrinsic pathway is that it is triggered by exposure to high negatively charged surfaces. We use things in the lab for the PTT, such as kaolin, but they're artificial. And of course, we have a somewhat revised view of coagulation these days that really questions the role, as I've already alluded to, of factor 12, high molecular weight kininogen, and prekallikrein. Do they have anything at all to do with coagulation, at least in the laboratory and perhaps in hemostasis? So a few years ago, Jim Morrissey's lab in Illinois started to characterize polyphosphates, which are present in high quantities in platelet-dense granules, about in the millimolar range, 100 millimolar range. And they're released from the dense granules of platelets when these platelets get activated. Now, there are analogs in biology of these in lysosomes and mitochondria and bacteria in particular have high levels of polyphosphate. And this is a very, very simple structure with these repeating units of phosphate. But note the extreme negative charge on the polyphosphate, which Morrissey's lab showed could have effects on coagulation. And actually, this is a two-part figure on the left here. Long-chain polyphosphates are really more characteristic of bacteria. So these, just the number of repeating units when they're well over 100, maybe into 1,000 plus range, that's when they really become efficient at activating factor 12. But they can have other effects, procoagulant effects on coagulation that Morrissey described in this, and I won't go into some of these other effects, but they can promote factor 5 activity in the prothrombinase complex, the feedback of thrombin-mediated factor 11 activation. Now, platelet polyphosphates are somewhat shorter, and in that size, they have a somewhat more limited, perhaps, activity. One of which is to activate factor 11 or promote thrombin-mediated activation of factor 11, and the other being in the prothrombinase complex here. So this is the first thing, that there may be some differences between bacterial and human polyphosphates. So we use mouse models increasingly these days to give us hints and clues about where to take these studies into humans. What we're looking at here is the mouse model, the knockout mouse for factor 12. And like humans who are knocked out for factor 12, who really have no factor 12 at all, I don't know if you've seen these patients, but they're asymptomatic. They have APTTs that are 400 or 500 seconds when they're really low in factor 12. But they really don't bleed at all. And the same with the mice here, that when the tails are transected in wild-type mice, this is the range of bleeding times you get. In the factor 12 deficient mice, very similar. So it's not at all different from the wild-type mice. When you add heparin to the wild-type mice, however, you induce bleeding in this model. So using these mice, this is from Thomas Rene's group at the Karolinska in Sweden. This was really the first probably in vivo study looking at polyphosphates. So what they did was infuse intravenous polyphosphates into mice, various types of mice. So here, when you infuse polyphosphates into wild-type mice on the left-hand group here, you see that they survive minutes. And in the top right panel, if you look at the lungs, you see that the lungs are full of pulmonary emboli. And that's what these red staining areas are. These are thrombi. On the other hand, the factor 12 mice, the factor 12 deficient mice, when they were infused with polyphosphate, had a very different kind of survival here, that they largely did very well when polyphosphate was infused. Now, you could mimic that essentially in the wild-type mice by using a pharmacologic inhibitor of factor 12. So instead of genetic factor 12 deficiency, you have pharmacologic factor 12 deficiency. And you see also that they were protected, these animals, from thrombosis. When you took the 12 deficient mice and reinfused them with factor 12, they started to become susceptible to the effects of the polyphosphate. So this suggests that polyphosphate can be procoagulant, and it can do so in a factor 12 dependent manner. But this is a model. Nonetheless, this field sort of took off in the last 5 years, and this is a summary of what is being proposed. Right now it's a hypothesis, but the question is it truly correct? On the left-hand panel, we're looking at hemostasis. On the right-hand panel, we're looking at thrombosis. And there's a suggestion that you can actually pull these two things apart. So in hemostasis, when there's vessel injury, tissue factor is exposed and leads to thrombin generation and the platelet adhesion and so on. We get a protective hemostatic clot. On the other hand, in thrombosis, what happens is that it may be a different process here, that the accumulation of platelets and so on leads to the release of polyphosphate. Now, I should say that the procoagulant effects of polyphosphate may then kick in and worsen the hemostatic clot. So it's no longer a hemostatic clot, if you like. Thrombosis is a different process, in other words, as postulated here, from hemostasis. And this is really what we'd like to be able to do, is to separate these two when it comes to developing antithrombotic agents. So, complicated figure, but let me walk you through it. This is a more contemporary view of coagulation, not so much what we teach our medical students in terms of the intrinsic pathway and the extrinsic pathway. This really sort of integrates the various interplay between, and really sort of speaks to the role of factors 11 and 12. So let's focus here on factor 11 getting activated to 11A. Now, when we do a PTT, we're going to generate 12A because we're adding kaolin or whatever. And that's going to drive the activation of factor 11 to 11A. But David Galani and George Brose showed quite a number of years ago that thrombin actually in vivo is probably the more important way of activating factor 11. So there's not one, but probably two ways of activating factor 11 in vivo. And this is important because it allows you to compartmentalize these various pathways. So here's hemostasis. Here's our tissue factor 7A that gets it all going. Here's our 8 and 9. We generate thrombin. There's a feedback activation of 11, which can then generate further 9A. So as coagulation people, we're kind of over on the left-hand side here. However, the contact activation proteins are all over here, factor 12, high molecular weight kininogen, and prekallikrein. And certainly the negative charge is important in causing contact activation of 12, activates prekallikrein, you get feedback further 12 activation. You eventually get inflammatory molecules like bradykinin. So factor 12A, there's an arrow here that factor 12A may have some other effects that have been described in vitro, like fibrin stabilization. So factor 12A, as I mentioned, maybe under some circumstances, maybe thrombosis rather than hemostasis, can get involved in thrombin generation, which can, what happened? That's not good. Can have effects on the clot structure. However, factor 12A may also have some effects on the fibrin structure and as such have a direct procoagulant effect. So going back to our figure here, we've looked at fibrin stabilization. Now we're getting over here into the effects of blood vessels. And you can see that both bradykinin, which is generated in large amounts in patients who have hereditary angioedema, who are lacking C1 esterase inhibitor and have factor 12 activation. And it might interest you to know that factor 12 is a major target now in the development of agents for hereditary angioedema. So nothing really to do with coagulation, but over here, what you're really trying to dampen down is the bradykinin production in vivo, which certainly can be a 12-dependent phenomenon. So bradykinin can have effects on blood vessels here that are related but somewhat independent of coagulation. So we come to this kind of situation that we have this factor 12 can get activated perhaps by these negatively charged collagen, perhaps polyphosphate. Maybe there's some good data on DNA and RNA in high quantities can activate factor 12. But then what happens? You generate 12A, but what does it do in vivo? It's normally inactivated by C1 esterase inhibitor. But this is a crossroads, a true crossroads. 12A has to really think about whether it's going to get involved in coagulation, if I can make it a thinking molecule, or whether it has effects that are being described in the complement system, whether it gets involved here as in hereditary angioedema in the kallikrein pathway leading to vascular inflammation and angioedema, or actually factor 12A can have a pro-fibrinolytic effect in modulating fibrinolysis. So it's really, I call it a multitasking molecule, a very interesting molecule that is really coming back into a lot of people's radar screens in terms of an interest. Okay, so taking it from biochemistry to whole animal models, this paper that was published in 2012, I think it was like an all-star lineup of everybody who's anybody in coagulation. So everybody took this paper to be very important. It was published in Journal of Experimental Medicine. And you can read the title. It was looking at the role of monocytes, neutrophils, and platelets, and show that they cooperate to initiate. And we often don't know what initiates coagulation in venous thrombosis as opposed to arterial thrombosis. But this is a mouse model. And so let me walk you through this a little bit. And to do so, I just want to back you up to something else you've probably heard about, which is the discovery of neutrophil extracellular traps, nets, and the process of forming nets when neutrophils become activated. And it's shown schematically on the bottom here that there's a sort of condensation of the granules, a nuclear translocation, and basically the end result is that the neutrophil disgorges or spews out DNA, in which certainly has an antibacterial effect. Net is a great term to describe this, because I think about a fishing net. You throw out a net and you catch the fish, and neutrophils do this to catch bacteria. But there's also been a lot of interest in whether they can promote coagulation. So this summarizes partly what this paper in mice was looking at, but also a lot of work from Denise Wagner's lab, suggesting that neutrophils, when they're getting activated, and we don't normally think of neutrophils as being very involved in venous thrombosis, but anyway, the hypothesis goes that neutrophils disgorge this long net, which is DNA. It's decorated with enzymes from the neutrophils like myeloperoxidase and elastase. And as Wagner's group and others showed, that maybe the high concentration of DNA is responsible, maybe not, in the net. But anyway, that this can get involved in contact activation. At the same time, although neutrophils don't make tissue factor, they can probably, this is like the sticky substance, if you like, the DNA that's capturing microparticles with tissue factor that can get you extrinsic pathway activation. And this, this eventually leads to what has been termed immunothrombosis. So in the presence of infection, where neutrophils are really getting turned on, we know that patients with sepsis can get into trouble with coagulation and thrombosis. But it may be the hypothesis in the study that I'm talking about was that really maybe this is more common as an initiating event in venous thrombosis. Okay, maybe right, maybe not. Let me show you some of the arguments for that. So if we simplify and boil down this paper, which is very complicated, has a lot of figures, a lot of videos, it's got a huge amount of data in, but basically let me boil it down for you. They were looking at specifically the effect of neutrophils, platelets, and factor 12 in this mouse model of IVC stenosis. So what you do is you tie off the inferior vena cava, and although that causes stasis, obviously, there's probably some vessel injury as well. And this is important because what model you use for venous thrombosis is important for the conclusions that you make, as I'll show you. Anyway, the end result is thrombosis. So here's our endothelium and our vessel wall here. So essentially what they did with all these studies was, if you want to look at the effect of neutrophils, you kind of knock out the neutrophils in the mice and see, did it modulate thrombosis? If you want to look at the effect of platelets, you knock out the platelets, factor 12, et cetera. And they suggested in this paper that all three of these things were important for venous thrombosis in the IVC model in mice. So this, was really kind of changing the thinking a little bit in terms of venous thrombosis, pathogenesis or etiology of the thrombosis. So they suggested that platelets, neutrophils, and factor 12 are all required for the initiation and propagation of venous thrombosis in the mice. However, mice are mice, and they are not humans, and more importantly, the model you use is really important, and there's a bunch of different models that have been used to look at venous thrombosis in mice. And this is a review paper that's looking at ferric chloride model, the IVC ligation model, the IVC stenosis model, the electrolytic IVC, it's electrolytic injury to the IVC. So they're all different, and indeed, we fast forward a few years here to this paper, which just came out a few months ago in Blood, in which we can ask the same questions in a different model. What's the role of the neutrophil, a platelet, and factor 12 in venous thrombosis in a different model? Now, this model is one in which the antithrombin and protein C levels are critically reduced in these mice, both of them. And so these mice actually develop spontaneous clots. You don't have to induce any vessel ligation, or you don't have to injure the vessel with electrolytic injury or ferric chloride. They develop spontaneous clots, venous. And these tend to be in intracranial large veins and fibrin deposition in the liver. So to cut a long story short, and going through the same drill in these animals by individually looking at platelets, neutrophils, and factor 12, they show the platelets were important. But factor 12 was not important in this model. In fact, knocking out factor 12 in this model, in addition to the protein C and antithrombin being low, it didn't protect against thrombosis. If anything, it may have promoted thrombosis, which is what this red line shows. And the neutrophil had no effect. So this gets at the whole issue of neutrophil nets and whether they're important. And again, it may be model dependent. So to summarize here in this paper, that the antithrombin and protein C knockdown mice, although platelets were also required, neither factor 12 nor neutrophils seem to play any role here. So, these are interesting and hypothesis-generating studies. So what about humans? Well, I put here the quest for the Holy Grail, and the Holy Grail in anticoagulation, as I mentioned, is really to have an agent or agents that prevent thrombosis or prevent extension of thrombus without causing bleeding. In other words, don't affect hemostasis. And the question has always been, are these one and the same things, or can you divorce them? So if we look at the DOACs here, direct oral anticoagulants, and this is a summary of the bleeding, the major bleeding in phase 3 clinical trials of the 10A in direct oral 10A inhibitors as well as dabigatran, you can see that compared to vitamin K antagonists here, they all had a favorable profile. But I just came from next door listening to my colleague Stefan Moll talking about reversing direct oral anticoagulants, and he pointed out that 1 in 300 patients per year is still going to have a major bleed on an oral anticoagulant. So we've made progress and over vitamin K antagonists, and of course this is in the setting of clinical trials rather than the real world. But is this good enough? And given the number of people who are on anticoagulation, I think I would make the argument there's still room for improvement. And this has begun. You may have seen this paper. It was published in the New England Journal the end of last year. And this was using a factor 11 antisense oligonucleotide in humans undergoing total knee replacement. Basically this agent works by, it's an oligonucleotide which is taken up in the liver, and it binds to the messenger RNA. In this case, it's engineered to bind to the mRNA for factor 11, and this prevents basically the translation of the message for factor 11 and reduced factor 11 levels in the individual receiving it. So so I'll read you here. The incidence of venous thrombosis, and this was detected by venography 8 to 12 days after surgery. They looked at 2 dose levels, 200 milligrams of factor 11, 300 milligrams of factor 11 ASO. These two, and then compared it to enoxaparin. Oh, don't like that. Sorry. Not sure what happened here. So this study was obviously using a well-tried and tested model of venous thrombosis prevention in humans, and this is usually where anticoagulant therapy begins its journey towards licensure, is in the prevention of thrombosis after hip or knee surgery. So these patients who had their factor 11 levels knocked down significantly into the 20% range, the venous thrombosis occurred in 27% at the lower dose of the antisense oligonucleotide, and in 4% of the higher dose antisense oligonucleotide, compared to 30%. Remember venography here of patients who received standard therapy, standard of care, which was prophylactic doses of enoxaparin. So this was superior. The rate of bleeding here was actually maybe a little bit lower. It wasn't statistically different, but by inhibiting factor 11 compared to inhibiting factor 10A, very favorable rates in terms of bleeding. So we probably know if you take care of factor 11 patients, deficient patients who are in this range, mostly we're going to be fairly comfortable sending them for hip or knee surgery. This might be a different story if they're going to get prostatectomy or tonsillectomy or other things in a high state of fibrinolysis. Maybe the bleeding at a low level of factor 11 is going to be a different story. But at least this, I think, establishes proof of concept. So this is what's happening really in the industry. This is Jeff Weitz's review from earlier this year. It's probably out of date already. But there are various approaches ongoing. I've talked about antisense oligonucleotides. This study here, this one that inhibits factor 11 as an antithrombotic. Interestingly, the company that's working on antisense oligonucleotide for 12 is targeting hereditary angioedema, not thrombosis, which is interesting. So this is a slow on, slow off. It takes a while, it takes quite a number of days, if not a couple of weeks, to really knock down the hepatic synthesis of factor 12 or 11, but it's quite durable. And it's reversible. Antibodies are being developed to 12 or 12A, and similarly for 11 or 11A. For some reason I don't really understand. It's very difficult to develop small molecule inhibitors of factor 12, but there are 11A small molecules in development, and the same with allosteric inhibitors. And then on this side, aptamers are essentially again, a kind of a nucleotide that essentially knocks down factor 12 in this case. So there's definitely interest in this in industry, but the question is, where is it going to fit in? And so we've been talking about venous thrombosis. I haven't deliberately talked about stroke or myocardial infarction, but let's talk about another form of thrombosis, and that is in patients who are getting extracorporeal devices. ECMO is one example here, but there are many others where there probably is a situation where contact activation with an artificial surface does arise. Left ventricular assist devices may be another relatively common one, for example. So here in ECMO, essentially, as you know, what is done, this is an artificial oxygenator, is that patient's blood goes through an oxygenator and then essentially is returned to the patient because of severe lung disease used in ARDS, et cetera. Very simple description of a complicated piece of machinery. But in this model, this is in baboons. This is again from Thomas Rene's group a year or two ago from Karolinska in Sweden, showing that when these animals, which typically receive high doses of heparin, when they receive just a saline placebo, the pressure in the system goes up very quickly, meaning that fibrin is formed. And there's pictures in this paper of fibrin formation in the system. If they are on heparin, the time on ECMO is on the x-axis here, that the pressure is maintained at a low level. 3F7 is an antibody to factor 12A. And in this model, it also seems to work as well as heparin in terms of perhaps not incurring the same bleeding risk as heparin, and this is shown, I'll get into this over here, but certainly from a pressure standpoint, maintaining the pressure. And indeed, if you look at the fibrin deposition that's quantified here, this is with saline. This is where they develop a lot of fibrin in the system. This is with heparin, but we don't really know how it's working because it's it's a 10A and thrombin inhibitor, essentially. And this is the 12A inhibitor, the 3F7. So on these animals, they did a cuticle bleeding time, which means cutting into the tissues below the cuticle. This is not just platelet dependent, this depends on the hemostatic system. Saline here, obviously they're not anticoagulated, very little bleeding. Heparin, as you'd expect, quite a lot of bleeding, and the 3F7 antibody, essentially no bleeding. So is this the best of both worlds, so to speak? Well, maybe. We'll have to see, but certainly it's very interesting, encouraging data. So I'll just finish with this slide that, in my opinion, one of the weaknesses of the literature is that factor 11 and factor 12, as in my title, are often considered together, whereas really they should be considered separately. It's very clear that factor 11 has a role in hemostasis, that it's different from factor 12 in many ways. So I think we already have at least proof of concept from the antisense oligonucleotide study that factor 11 could be a potential target in venous thrombosis. Again, we'll have to see what comes next. The preclinical evidence, as I showed you with the baboon model, suggests maybe where we should be looking with factor 12 inhibition might be not only hereditary angioedema, but also in I'm really talking about the last point here, but let me say that first. So factor 12 may be really a viable target in device-associated thrombosis. But I did mean to say here that be careful about interpreting the animal models because it really is, it seems to be model dependent. So a lot of my basic science colleagues who I highly respect can get very married to a hypothesis through their animal model because they're using a particular model. And it certainly contributes to the knowledge base, but it's a difficult thing when it comes to venous thrombosis because we don't really have a perfect model of venous thrombosis in animals. And I'll just stop there. Thank you very much for your attention.